Hi everyone, I am Dalia Ibrahim and this is Dalia Case Collection. Today we will have a quick quiz of 3 kids who are complaining of microcephaly. Their clinician suspected craniosynostosis, but actually we have a different diagnosis for each case. So let's get started with the first case. This is a 1-year-old boy who is complaining of microcephaly, as I said. Okay, and I will scroll through the axial views and the sagittal and the coronal and the 3D volume rendering, and you try to identify the salient abnormality in this case. Okay, I will start with the 3D volume rendering, and this is the best images. I love to check for the suture, for the patency of the sutures, or for the fractures. It's actually much better to examine those structures, the skull bones and the sutures and the fontanelles on this views more than the classic axial brain or bone window, because it's easy to identify the sutures and very easy to identify even subtle fractures. Here, in this case, we can see the coronal sutures, the sagittal sutures, and the lambdoid sutures are all open. We don't have any premature closure of the sutures. We don't have any craniosynostosis. The metopic suture is closed because this boy is 1 year old, and the metopic sutures actually closes at 6 months of age. So the answer of the clinician, we will answer him, was no, we don't have any premature closure of the sutures. We don't have any craniosynostosis. Okay, why there is microcephaly for this case? When we examine here, the striking features here are the dysmorphic, the clear, the dysmorphic and this irregular appearance of the cerebral mantle here on both sides. The cerebral hemispheres appear dysmorphic, disorganized. This is not the normal appearance of the cerebral hemispheres. Also, we can see there is a smooth surface of the brain. We can see the normal sulcation and gyration. Only a few of them seen or evident on the left frontal lobe, but the rest of the cerebral hemispheres are smooth. Okay, as we can see with the thick cortex and the smooth surface of the brain are impressive of the pachygyria-lysencephaly spectrum. So we don't have only the disorganized or dysmorphic appearance of the cerebral hemispheres, but also we do have pachygyria-lysencephaly spectrum. And if you focus a little bit, you can see here small periventricular patches of low attenuation, which represents gliosis. Okay, and the striking feature for this case, or the salient abnormality, the presence of multiple small microcalcific foci scattered within the cerebral hemispheres, and here along the periventricular region at the temporal, along the temporal horn. And that's the most important finding, radiographic feature for this case, because it's a clue for what disease. Yes, the clue for the torch infection, specifically when you see the calcification are along the periventricular regions or the basal ganglia regions, or scattered like in this, are impressive of cytomegalovirus infection. When you continue with the case, you can see here there is arachnoid cyst here in the quadrigeminal cistern that will lead to splaying of the cerebral hemisphere here on the sagittal images, and the coronal just showed you clearly the scattered microcalcific foci here. So how to report this case? Actually, you have to say, number one, in your opinion, you will say that you do have microcephaly. Okay, you believe that the clinician is right in this case. This case really have a microcephaly, but you have, number two, you have to answer him. You have to answer his question in your report, that you have to tell him there's no evidence of craniosynostosis or premature closure of the sutures. Okay. Number three, you have to give him the reason for this, which is for the microcephaly in this case, which is we have here the abnormalities, the dysmorphic appearance, disorganized appearance of the cerebral hemispheres, and the pachygyria-lysencephaly with a scattered microcalcific foci are all secondary to torch infection. And actually, when we have reported this, the clinician performed cytomegalovirus antibodies for the mother, which were positive. So that was a case for torch infection with cytomegalovirus, and that had led to the microcephaly. Okay, microcephaly, as we will say, that microcephaly is divided into two major types: the primary type, which is genetic or syndromic, and the secondary type. The secondary type, the brain of this kid actually was developing normally in utero, but when the mother had been exposed to the infection which had been transmitted through the placenta to this, it had ruined the normal development of the brain, leading to the abnormal and the small and dysmorphic appearance, which subsequently will lead to the small size of the skull, because the brain will not grow normally, and so as the skull will not grow normally as well. So, but this patient before this infection had the normal genetics, normal development of the brain until maybe the 5th month of pregnancy or the 6th month of pregnancy, when the mother had been transmitted the infection to the baby. Then the normal development will stop, and it will be ruined, and it will ruin the normal development of the brain and subsequently the skull. That will what we call secondary microcephaly. Okay, secondary to an insult that this infant had been exposed to. Another example here we have, this is an easy one actually. Okay, this is also a girl, she's 3-year-old, and she's complaining of microcephaly, and we can see here on the surface rendering, okay, she had microcephaly, we believe in this, okay, and she has another abnormality. She had reported that she had a history of cleft lip and cleft palate, but it was treated when she was younger in age. And the 3-volume rendering here, we can make sure that this is not craniosynostosis. We have normal appearance of the coronal, sagittal, and lambdoid sutures. But on the axial images, can we see the salient abnormality here? The striking abnormality is the absence of the falx here and the presence of fusion of the frontal lobes together, with the absence of the frontal horns of the ventricles and the presence of monoventricle, just one ventricle was absent, septum pellucidum. All those are features of semilobar holoprosencephaly. So this girl had semilobar holoprosencephaly that had led to, again, abnormal development of the brain, the small size of the cerebral hemispheres with subsequent small size of the skull in this case. So this is a case of semilobar holoprosencephaly with microcephaly. The third one, actually, the third case here, we have a hard one. This is a hard case. Okay, this is a 1-week-old. This is a 1-week-old boy. Okay. Was complaining of microcephaly, as we can see here. This is a microcephaly on the sagittal images, and we have a small corpus callosum. But on the axial images, the striking thing that the reduced sulcation and gyration of the here in the cerebral hemispheres. So you can say, you have mentioned that could be Brachygardia lysencephaly syndrome. Actually, no, it's not, because in Brachygardia lysencephaly, as we have seen the case before, we have seen, like this case, we can see thick cortex here. This is thick cortex, but in this case, okay, you can see there is a very thin cortex. It just shows abnormal sulcation and gyration. And this is what we call primary microcephaly, or microcephaly with simplified gyral pattern. I will show you the difference here. Okay, you can see the difference here. Can you see? This is a normal. This is a normal 1-week-old baby on the left side, and this is a 1-week-old with simplified gyral pattern. You can see the small microcephalic appearance here. Okay, on the left side, and the normal appearance here, and on the here on the axial images. This is a normal, as I said, normal 1-week-old. Can you see the normal sulcation and gyration here, and compared to the abnormality here? They are totally different, okay? And again, there's very thin cortex, so this is not Brachygardia lysencephaly syndrome, but with the presence of the microcephaly and combine them with the reduced sulcation, we can say that this is a case of microcephaly with a simplified gyral pattern. We have another case. This is a microcephaly case. Okay, here this is a case of microcephaly, and you can identify here the case in this. Okay, we have multiple small appearance of cerebral hemispheres, but multiple cystic areas involving the parenchyma of almost all the cerebral hemispheres. That's actually what we call cystic encephalomalacia, and it's likely secondary to severe extensive hypoxic ischemic insult that also had led to microcephaly. So here we can, as I told you, we can divide the primary the microcephaly to primary type okay, or secondary type. The primary type, as we have mentioned, like in this case, this is a genetic disorder. This boy had multiple brothers and sisters with the same disease. So this is primary